Right. I love that sentiment too. Well, welcome everybody to our last meeting of 2025. So welcome to our Empowerment Congress Homelessness Working Group meeting today, December 11th, 2025. I can't believe that 2025 we are in the final month of this year. So I'd like to welcome everybody to our meeting. I am going to go ahead and drop the agenda in the chat. There is also some additional information on the chat, so we would request you to periodically refer to the chat throughout this meeting. As we get started with today's meeting, I would love to start with some introductions. So we'll go ahead and share your name, your affiliation, and then we will popcorn it around. So my name is Rhea, and I am the co-chair for our Empowerment Congress Homelessness Working Group. And I'm going to pass it on to Mr. Vincent Harris.
Good evening. I am Vincent Harris. I'm the project director for the Empowerment Congress and enthralled by the leadership being displayed by Rhea Mack.
Okay.
And with that, I'll pass it along to Marvin, I mean, excuse me, Jesus.
It's okay. I've been called worse. Hello,
Mar-
Marvin Espinoza. I'm a Chief Operating Officer at Girls Club of Los Angeles. Very happy to be here and looking forward to today's meeting. Good to see you all. Greetings. I will pass it on to, is it Miss Williams, Placidia? All right, she might be away from her line, so I'm gonna go to
I just
Cheryl. Hey, Cheryl. Oh, go ahead, ma'am.
I just unmuted. My name is Placida Williams. I'm with community faculty at Charles R. Drew University.
Drew in the house.
Yes, thank you for joining us. Who would you like to pass it on to, Miss Williams?
Oh, I can't see anyone else. So I'll pass it on to who's on? I can't see.
I can pick for you if you'd like.
Okay, go ahead.
Okay, I'll pass it on to my favorite supervisor, Supervisor Mark Ridley Thomas.
Okay.
Thanks very much. Delighted to have everyone here. And I'll have a little bit more to say later, but it's great to see you on the call. And I am pleased with the breadth of those who are on the call already and the diversity of views and experience. And toward that end, I would like to now pass it along to the one and only Cheryl Branch.
Thank you, Supervisor. Cheryl Branch here with the Los Angeles Metropolitan Churches, and I'm representing our homeless subcommittee.
Great. Pass it along.
Okay, who did not go? I think Monique. Did Monique or Mary Jones? I see those two in my Hollywood Square.
well, that's a throwback.
I love that.
Mary Jones, are you available? Or Monique?
Mary and Monique, you're both muted.
Okay, I'm just logging in. I'm not sure available for what.
Intro.
I just said
Oh, I'm
intro.
sorry. Oh, okay. Mary Jones, retired government employee, longtime member of the Empowerment Congress, staff of MRT.
Yeah, that's Mary K. Jones in the house. Monique?
I think Monique's computer has no mic, so Monique, if you'd like to put your introduction in the chat, we would be more than happy to read it out for you.
Yeah.
And we'll pass it on to Mr. Ricardo.
Hello, everyone. Uh, my name is Ricardo Forbes. I do grant administrative work for Central Neighborhood Health Foundation. We're an FQHC and LA, San Bernardino, and Riverside County, serving over 26,000 patients each year who are medically underserved. And I was invited to be on this call by Ria, and I've been doing some collaboration with the supervisor in Ria, and so I'm happy to be here.
Thank you for joining us.
You're welcome.
Welcome to the party.
Thank you.
And we will pass it on to Dr. Hochman for your introduction.
Yeah, very honored, happy to be here. Michael Hochman. I'm a primary care doctor. I do a lot of work in homeless healthcare, and I was Supervisor Ridley Thomas's senior health deputy for several years.
That is awesome. Thank you for joining us, and we look forward to hearing from you later this evening. We'll pass it on to Miss Joanne Russell. We're doing introductions, Joanne. And Joanne, you're muted.
Good evening, everybody. Joanne Russell, Let's Make It Happen, long time EC member, and glad to be engaged. Happy holidays.
And you, Joanne.
Thank you, Joanne. And we'll pass it on to Mary Porterfield.
Yes, good evening. I don't have my picks up because I'm actually on the move, so I'm listening in. But I out of Long Beach, but I am an educator, freelance writer, and have been a part of EC for some time on the education committee.
Oh, wow, that's amazing. Well, thank you for joining us, Mary. All right, and I think Monique put her introduction in the chat and shared that she is a longtime resident of Los Angeles and a grassroots activist. So, again, thank you so much to everyone for joining us this evening. Before we get started this evening, I'd like to recap our last meeting, which was on November 13th, and that was just 2 days after Veterans Day. And so we were very honored, and I was very excited that we had Jim Zenner join us. He's the director of the Los Angeles County Department of Military and Veteran Affairs, and he shared a number of updates and interventions that DMVA is engaging with for veteran services, but also to support our unhoused veterans here in Los Angeles County. Amongst which he shared an interesting kind of peer support model called the Veterans Peer Access Network, or VPAN. And so we're excited to share that we are going to hear about some additional innovations and models later this evening, just to build on different ways to address, treat, prevent, and end what Supervisor MRT refers to as the moral crisis of our times, homelessness. But with that, I would like to pass it on to Supervisor MRT for both his remarks and an overview of my favorite editorial innovation, Praxis.
Thank you, Madam Chair. We appreciate it. I think you'll take note of the fact that Praxis should be in the chat. If not, it will be in short order. You note that we look at the matter of homelessness from a global perspective, and we start at the federal level and give you some things to think about and look at the state level, and we then move to the local level, because we believe that if headway is to be made, it will require not only innovation but cooperation. Not only cooperation but collaboration. And what we see in that regard is a need for federal, state, and local communication connectivity in order for that to happen. So these articles give an up-to-date view. It's a chronicling of what's happening at a variety of levels, tracing the roots of homelessness, as the first one suggests, the current administration's behavior vis-a-vis homelessness and what our assessment and critique of that should be, um, how we move through and survive the challenges that confront us with respect to food insecurity being exacerbated, um, the housing insecurity that we know that drives homelessness. And many of these policies obviously emanate from the federal level. There's a level of pushback that's political in nature on the part of the state, particularly the governor, who I will assert has done more in the way of homelessness uh, intervention, advocacy, policy making, funding than practically all of his predecessors combined. And I don't fear being contradicted on that, having served as one of two co-chairs for the governor's statewide homeless task force. Both Mayor, then Mayor Darrell Steinberg, and myself, a colleague when we both served in the state legislature, we saw up close and personal how much this governor was prepared to do. And we also saw what he was not willing to do. On that point, I want to punctuate the issue of a right to housing. In my view, that is unfinished business. Um, and to the extent that that is the case, we need to find out how we move beyond discretionary considerations regarding housing to what is essentially a mandate or that which is obligatory in terms of people's rights. If we have a range of other rights, housing should be listed among them. And this has been articulated since 1948 in the Universal Declaration of Human Rights. So among those rights should be the house, right to housing that is maintained. You look further and keep a close eye on Judge David O. Carter, who's looking closely at what's going on with um, the region in terms of homelessness, encampment, and settlement. Look closely because now what we have is um, the judicial branch of government leaning in with respect to the issue of homelessness in Los Angeles and being very forceful in that regard. The question is how helpful has Judge Carter been over this period of time? I leave it to you to make your own assessment. The article is here for your review, but there are a lot of hands in this policy area. The question is, what are the results uh, uh, that tie to the involvement of the various people to which we make reference to, whether it's Judge Carter, whether it's Governor Newsom, or whether it's Mayor Bass, whether it's Supervisor Horvath, whether it's um, the President of the United States, whether it's a whole range of policymakers and leaders. Uh, what is it that they leave for us to build on that make things better than what they were? In that regard, I take the opportunity to point to someone who I think is a consequential player, public servant, moving from the space of the private sector as a founding CEO of Starfield Primary Care. He's introduced himself as a practitioner or clinician, primary care doc. Um, and we had the great fortune I did to have him as a part of my team when I was serving on the Board of Supervisors uh, and leading the the health team. A lot of the work that we were trying to think through in terms of public health, mental health, as well as health services, Dr. Michael Hochman played a role. He's an innovator um, in terms of street medicine. Um, he has some things to bring to our attention in that regard. We are anxious to hear. He's also no stranger to academic medicine. Um, Harvard is where he did his training, served in a number of capacities at the University of Southern California, and just continues to be a witness for things that speak to the fundamental dignity and worth of every human being, particularly those who find themselves yet unhoused. And with that, I say he's an author, uh, he's a husband, and most importantly, he's a father. We offer you now Michael Hochman for his remarks.
Well, it's an incredible honor to be here, Supervisor Ridley Thomas. Since you mentioned the father part, uh, when I first started working for Supervisor Ridley Thomas as his senior health advisor, I met his son Sinclair at a party, and I said, "I work for your dad. Great guy." And he said, "Don't we all?"
Yeah.
so, so now I think I get that dynamic.
Thank you.
Let me share my screen here.
Before you do that, Dr. Hochman, let me just say that I've been retired for 10 years now, and I'm still working for the dude.
Okay. Thank you so much, Vincent. Um, I'll be doubling your salary pretty immediately.
Yeah, I think probably a lot of people in this meeting have a similar situation.
Amen.
Well, I'm very, very honored to be here. I've seen the Empowerment Congress grow during my time. I'm going to talk today about caring for unhoused patients in an effective and sustainable way as a doctor. I'm going to begin by just talking a little bit about how my time with MRT really shaped what I've done over the last 5 or 6 years. The challenges of providing homeless health care, about the initial homeless healthcare organization I founded, Healthcare in Action, and then some policy considerations for us to talk through. Please feel free to jump in. I'm very happy to turn this into as much a discussion and less of a lecture. So there's many things I took away from working with Supervisor MRT. When I first started working with him, I was inspired by his rhetoric and his way to take complicated ideas and present a coherent vision. But from working with him, what I really took away is, and I think this is a term you use, Supervisor, correct me if I'm wrong, he'd say I'm a pragmatic liberal. And
Mhm.
what he means, I think, by this is you can talk and speak all you want, but until you tangibly accomplish something, um, that doesn't hardly worth the paper it's printed on, what you say. And there's two things in my view in healthcare that the supervisor in the county of Los Angeles, the supervisor has fundamentally changed in the health field. I'm sure there's other fields, but I'm most attuned to the impacts he's had on health. First is when I first moved to Los Angeles, as many of you know, Martin Luther King County Hospital was closed. That's a whole nother story. But if you haven't read the LA Times story about that, it's worth reading. And it was a really upsetting time in healthcare for safety net healthcare. And Supervisor Ridley Thomas was the person who stood up and was a pragmatic liberal. He didn't just talk about the need for health equity and access, but he made a lot of phone calls and did a lot of fundraising and did a lot of the scut work. And he created what is now, and I can say this confidently, the best safety net hospital in Los Angeles County. It is better than the other county hospitals. It is better than the other private ones. It's not perfect. There's still a need for more emergency room beds. I think there should probably be a second tower there because they're bursting at the seams. But he really showed that you can create a highly effective safety net hospital. And it's the best one that we have, and I think there's no one we owe that more to than Supervisor Ridley Thomas. Do you want to say something about that, Supervisor?
No, I'm just taking it all in for right now. I'll keep going.
The second thing is in terms of bioscience. When I was starting to work with the supervisor, we looked at San Francisco and San Diego, and they were not only making great advances scientifically, but it's a great job engine. And there's no one who's played a better role in lifting and elevating LA and the bioscience establishments, both the scientifically and the jobs, than Supervisor Ridley Thomas. I think we still have a long ways to go there. So since working there, I've decided, I don't want to be a talker. I want to be a pragmatic liberal. I want to be someone who implements things that makes the lives of people better. And that's what I tried to do with homeless healthcare. So,
Nice.
There's unfortunately, I don't think is going to be a surprise to anyone on this meeting, been just a continuous rise in the homeless population. I haven't seen the latest data, but it's been about a 7.5% rise pretty much every year for the last several years in the homeless count in the United States as a whole, but also in California. Here in California, we have a particular challenge with the unsheltered population, presumably for the weather and various other reasons. And the question is, how do you care for folks in this situation? They're the ones who fall through the safety net system, fall through the cracks. Even if you put up a great hospital and medical center like the MLK campus, these are the patients who aren't going to come in the door. And actually, it was also my time we were starting to learn about street medicine. It was a relatively new concept, not nationwide, but certainly in Los Angeles. Brett Feldman and his team were starting to do some work. The county was starting to do a street medicine team. But no one was scaling it and doing it systematically. And just another slide I wanted to show before I get in here, to make the point that homelessness and health are really inextricably linked. There is virtually no other population that has as many needs. So these folks are not only not getting into the healthcare system, but they are burdened with some of the highest rates of both physical illness, mental illness, and substance use. Now, there's been a lot of variation in what the studies show. So this is the comparison of the rates of a LASA analysis, an LA Times study, and then a UCLA study on the rates of mental illness, substance use, and overall health conditions. So the LASA analysis found that 25% of the unhoused in LA suffer from mental illness, 14% substance use, and 18% a chronic health condition. I don't know who they spoke to or talked to. The LA Times somewhere in the middle, and then the UCLA study showed it's the vast majority. And I can tell you from working with over 1,000 homeless patients myself directly over the last several years, the UCLA study is absolutely the one that matches my experience. An incredible burden of severe mental illness, schizophrenia, bipolar disorder, substance use, methamphetamines, fentanyl, and health conditions, HIV, hepatitis C, the list goes on. And it's really hard to tease apart what came first. Was it the homelessness that led to the mental health issues? And there's certainly stories that sound that way. Someone loses a job, ends up on the streets. Next thing they know, they're suffering from substance use. Or is it the mental illness that's primary? And I think it doesn't really matter. Once you get into a spiral, it's about how do we provide care for these folks. But this is my personal opinion. The UCLA study is the right number because there's just so much variation, and really health and homelessness are just so closely tied together. So I saw all this data, and Scan Health Plan, which is a Medicare Advantage plan based in Southern California, they did a job posting for the CEO to lead a street medicine program with the idea that these are the folks who are the most challenging, the hardest to treat, and also the ones who are not coming into our clinics? Could we bring care to them? And it can't just be medical care because there's so much mental illness and substance use. So it's got to be medical care, substance use treatment, behavioral health, and also case management. Could we integrate all these things and bring them together? And the dual goal of the program is to stabilize the health and facilitate the housing placement, right? So the two really are hand in hand. You can't be healthy when you're living on the streets. And by the same token, if you're not being treated for the schizophrenia and the drug use, you're not going to do well in housing. I remember, this is a tangent, when I was working for the supervisor, there was such a debate about individual freedoms and do we have the right to put someone in a mental hospital. I remember I got sucked into that whole debate and discussion.
Yeah.
And I remember the supervisor said, in what world is it humane to let someone who's got florid, untreated schizophrenia lie there on the streets and assert their right to be there on the streets? I mean, that's just not a humane thing to do. And that's not respecting individual rights either. So, that I think it was just such a simple, powerful way of saying it. And that's become my view on the issue. So what we tried to do is bring care to where they are. We view ourselves as a transitional primary care provider for behavioral health and substance use. It's not to say we want to be the primary care provider forever. In fact, it won't work if we don't graduate people and get them into housing and stabilized into the medical system, because if all our homeless doctors are following people forever, there's not going to be enough. So what we really need to do is have the view that it's a temporary relationship, transition, stabilize, and graduate patients. And such an important piece of this was having the case managers providing integrated housing services. I don't have a slide on this. There's a lot of housing service programs that are disconnected from the medical. And my view is both of these services, street medicine on its own without the housing providers, is nowhere near as good. And these things are just so synergistic that your success rate when you have the integrated medical and housing is so much better than either alone. And we did have some data on this, that the LAHSA case managers that were not connected to medical teams, about every 6 months, about 5% of their clients would get placed into permanent housing. And the teams that were integrated, where it was medical plus a housing navigator, is about 25%. Now, 25% is not a number to be proud of, but it really makes the point that these things are hand in hand and they're synergistic. So just some nuts and bolts. We not rocket science. We tried to recreate what we have in a typical medical office, a medical provider, typically a nurse practitioner or physician assistant coupled with a medical assistant. What's different from a typical medical environment is the community health workers who are doing the housing, navigation, the support. So if you see here, it's a ratio of 6 health support, ancillary support case manager staff to 2 medical staff. We had the doctors do the oversight, just for a cost efficiency standpoint. Being a pragmatic liberal, it's just not cost effective to take a $250,000, $300,000 a year doctor and just chase people down on the streets. So we would have the physicians play a supervisory role. Same thing with social workers. So it's just too expensive to have 6 social workers out on the streets for each team, but we have the community health workers out there in the field supervised and guided by a social worker. Okay. A typical team could care for 200 patients at one time. Because there's turnover, hopefully a lot of these are graduations, patients that we successfully get into housing, but some people we do lose to follow-up. Each team served about 500 unique patients a year. Okay. And so I was at Healthcare in Action from 2021 as the CEO until the end of 2024. We started with 2 teams, one in Los Angeles and the second one in San Diego. The reason being SCAN Health Plan had a lot of presence in those 2 counties. And about 3 months in, we got a call from the city of San Diego. Hey, we heard you're doing some help for our homeless population. Could you make another team in the Gaslight district? And then the county of Riverside heard about what we were doing. And, I spent, as supervisor mentioned, I was in academics for a while. Part of the reason I gave up on academics is I would spend so long writing grants all the time, and 90% of them wouldn't get funded. This was the first job I ever had where people started calling me and saying, if you're doing good work, we're here to fund you and support you. So over the course of 3 years, we grew from 1 to 16 teams. They continue to grow since I'm no longer with the organization. There are now 21 teams. There's a random team up in San Mateo. There was a philanthropist who heard about what we were doing and just funded a team up there. And as far as I'm aware, it's now the largest homeless healthcare provider on the West Coast. And we're serving about 3,200 clients at a given time. So here's a little bit on the data as of July 2024 in the first 3 years. The first one is the Net Promoter Score. This is a very simple question. Would you recommend this service to your friends or family? It's a score from -100, if everyone's saying, no, I'll stay away from these guys with a 10-foot pole, to giving it a 10, you would be recommending it. Just as a benchmark, the average healthcare organization has a Net Promoter Score of 25. So generally, people like their providers, they recommend it. Netflix has a Net Promoter Score they're very proud of 55. So our Net Promoter Score was 86. The vendor that did this with us said that's the highest they've ever seen for a healthcare organization. I think they had seen a couple other like Ritz-Carlton type organizations with slightly higher scores. And so the CEO scan asked, well, Mike, how did you get such a high Net Promoter Score? And, of course, to him, I said, because we provide perfect, excellent care, have all our processes in place. That's the farthest from the truth. We had a lot of operational challenges. What this is a testament to is how underserved these patients were and just how incredibly appreciative they were, how low the bar was, how little care they had been getting. And in comparison, us showing up as imperfect as we were, and I could spend a long time talking about all our imperfections and how we could do better, that the patients were just so appreciative that they ranked us so well and developed that trust. The statistic I'm most proud of is we had over 500 patients placed in housing. We counted a housing success going from the street to a shelter, or from a shelter to permanent housing. So 500 out of 6,000. On the one hand, that means there's 5,500 that we didn't achieve that success with. But again, if you compare that rate to what a non-medically based housing program is, it's much higher. I also get asked the question, well, of these over 500, and it was, I think, 625 by the time I left the organization, how many fell back into homelessness? I don't have the data on that, but one thing we did acknowledge is that it's a very vulnerable period when someone gets rehoused, and we don't leave you. Our goal is not to graduate you the day you get into permanent housing. We stick with you for 3 months, 6 months, until everyone's comfortable, and we do a warm handoff and transition. Gosh, I wish this number were higher than 500 out of 6,000, but I'm telling you, I'm pragmatic liberal here. I'm telling you the way it is. So the statistic that I cared about the most was that facilitated housing placements. The statistic that the health plans care the most about is cost. That's homelessness, hospitalizations. So we had a partnership with Cedars-Sinai. The reason they were very interested in working with us is they're in Beverly Hills, and they were having a lot of unhoused patients show up in their beds. They get paid a lot more when a Medicare patient shows up in one of those beds than a Medicaid patient who's homeless. So what they wanted us to do was help take their homeless patients, transition them, stabilize them, and prevent them from returning. Now, I said that in a very financially oriented way. I do think Cedars, I give them a lot of credit. I think their motivation was not just financial, it was also social mission, but nevertheless, they were very interested in the cost. So we did an analysis, and we get up to 199 patients that were enrolled and assigned to us, and we compared them to a matched cohort that did not receive the medical services, and there was a 24% reduction in ER and hospital utilization. And you could pen out the math, but hospitalizations are $1,000 a day. ER visits are $750 a day. So there's a lot of savings in the system from this work.
Dr. Hochman, let me
Please.
interrupt you for just a second.
Please.
Would that be in the criminal justice reform discussion? Is that comparable to recidivism?
Exactly right. So it's what percentage of these patients came back to either the ER or the hospital within 30 days of leaving the hospital. It was a 23.7% reduction in our patients compared to matched patients that didn't receive our services.
And the savings to avoid that amounted to how much again?
Well, I haven't done the cost analysis formally. A hospital bed day is about $1,000 is the rule of thumb, and an ED visit's about $750. So, if your readmission rate, and I think that for this homeless patient, it was almost 50% of homeless patients when they got discharged from Cedars ended up back in either the ER or hospital within 30 days. So it was a 25%. I think we went from about 48% down to low 30s, as I recall. So if you do 100 patients, that's 10 or 12 hospital days saved,
right,
at $1,000 a pop.
Thank you.
Okay, we got some good media attention. We got believe it or not, the front page New York Times story was about one of our patients in San Diego. There was a USA Today profile. We got the Orange County Cities Award and the Inland Empire Health Plan Creativity and Innovation Award. So it sounds really good. All right. Now we have one problem: cost, right? So to be sustainable and scalable, you got to have a sustainable business model. And unfortunately, that's not something we achieved while I was there. So these are the costs. Each team cost about $1.4 million to operate, and the revenue we generated was about $1 million. One interesting thing, this is not really the main point of why I'm saying this. The Medicaid reimbursement for the medical services, we got about $40,000. For the case management program, it was $960,000. So I like to joke that the social workers made about 20 times the rate that we doctors made. Just out of curiosity, any guesses what program that this is due to?
Don't know.
Medicaid doesn't pay for the full cost of service, right?
Well, you're right that why the medical costs were so, Medicaid rates are terrible. So that's why we got paid so low on the medical side. The case management side, the CalAIM program, you guys might have heard of, Enhanced Care Management. That is up for renewal in December of 2026. So one year left on that. We could not have done this without the Enhanced Care Management, the CalAIM program. So that's where a lot of this revenue came from. But even with the CalAIM program, 1.4 million is more than $1 million. So we were losing about $400,000 per team. All these gray hairs are from that. I was constantly writing grants and begging people, and the cities were bailing us out. The scan board wasn't happy with me because we were losing. We kept growing. So we had 18 teams. To Scan's credit, they have continued to fund it and subsidize the gaps, and they continue to try to to get grants and so forth. But that actually had a lot to do with why it was time for me to move on, because I think we capped out around 18 when I was there, and I could just see things leveling off. There's only so far you can go when you're running a loss every year. And my vision is to do this, to put mobile teams across the state of California and really be an important player in the response to homelessness. And so I noticed there was a FQHC CEO on the line today. The way I see this happening is as a federally qualified health center. Why? Because as Vincent said, Medicaid pays us about $70 per visit, and FQHCs, and not to in any way say that they're richly compensated, but it's about, correct me if I'm wrong, often $250 to $300 a visit. So if you can put together the enhanced care management revenue with the medical services revenue, I think we can get 1.4 million to cover the cost. Now you may ask, why did SCAN not want to do this? That's another nuance of the FQHC system. It requires community control. It needs to be a board that's 51%. It needs to be a 501c3 nonprofit with 51% community control. And SCAN, for I can say a lot of good things about them, but a lot of healthcare organizations like control, and they just weren't willing to become an FQHC and give up that control. I apologize. I can't remember the name of the FQHC head who was on. I'll pause and give him a chance to say a comment on FQHC financing.
Ricardo, was that your intervention? Or I think Jack Barber's on the line as well.
Mm-hmm.
Who else is an FQHC provider?
I think that those are the two on the line.
Yeah, hi, this is Jack Barber. And
Dr. Jack Barber.
Yeah, so I'm not an FQHC CEO, but I am a mental health agency CEO that works in the homeless sector as a result of our FSP programs and some of the other ones that have this as an area of focus. And so I put in the chat, I said, oh, gee, this must be reimbursed through ECM, because I couldn't see how the numbers made any sense. And of course, then you went into your description of that.
You should have said it out loud. That was my quiz question. You knew the
answer. Oh, really? Well, I put it in the chat before you started talking about it, because I kind of wondered. And I think I know some people on the SCAN board, but I just kind of wondered that, because I talked with them about working with us in a number of areas. I was wondering, I had so I understand how fragile the funding is with it going through CalAIM, which may not be here forever, like you just elaborated. But I kind of wanted to know if you had a relationship with a recuperative care entity or any of them, because the hospitals like Cedars or some of the other ones who don't want people clogging up their emergency rooms who have Medicaid because they lose so much money. There are models where they will actually pay for beds, and I just wondered if that was a part of what you did.
Oh, recuperative care is a brilliant
about that,
Yeah, recuperative care is a brilliant program. It's someone who's just sitting in the hospital getting some nursing care who could otherwise be in the community. Actually, supervisor had a big role on the MLK campus on getting, I think it's JWCH is the operator for that one. Again, pragmatic, liberal. And so we have so many dollars. Why spend them on hospital care for someone who doesn't need to be in the hospital? We were not ourselves a recuperative care facility, but we partnered with a lot. We would be the medical provider because they don't actually have staff medical providers. So we provide mobile services there. I've used the term street medicine, but only about a third of our patients were actually in encampments on the streets. We did a lot of our work in shelters and interim housing and in recuperative care facilities, places like that. Even some permanent supportive housing. We would follow people into permanent supportive housing. I actually prefer the term field medicine for that reason.
Yeah.
But as long as CalAIM is around, my view is that the FQHCs have an opportunity to provide this service in a sustainable way. So actually, that I'll just say that I've left Healthcare in Action. A new group I'm starting is called Starfield Primary Care. I'm trying to convert it to an FQHC and do exactly this. So that's the journey I'm on right now.
You got to get your PPS rate up, huh?
Exactly. So the politics of it all, and then we got to figure out a what's going to happen with CalAIM and the enhanced care management. Now, recuperative care is paid for also by CalAIM with the community support services. That's also a threat. What I've heard at the state level is they're going to try their best to preserve enhanced care management, but if the feds don't approve the waiver, the first thing that's going to go is the community supports like recuperative care, which is just heartbreaking. And it's hard to imagine the feds with this administration approving the waiver as is. So I just have 2 or 3 more slides, just some personal observations. And then I really would like, I'm not a policy person, I'm a doc. so I was hoping to turn the mic over to the people who can think on the strategy side. Just my observations from observing the housing system up front and firsthand. It's incredibly painfully bureaucratic. The amount of paperwork, the amount of times you need to show your driver's license and fill out the same forms, and to have someone with severe mental illness complete this, I mean, I can barely do it myself, and let alone someone with serious mental health issues. There's always a talk about shortage of housing, and I'm not, please do not interpret this to say that I don't think there's a shortage of housing. There absolutely is, but there are also unused units out there. I see it in front of my eyes. I see recuperative care facilities where half the beds are filled. I see permanent supportive housing where there's a couple beds available. And I've asked, why aren't these beds filled? And the reason is staffing, that they don't have enough staff to staff the beds. So everyone talks about a housing shortage. I actually think the even greater limiting reagent is staff. And that's in part because we pay $26 an hour for this work. And that gets to the third point here. There is a crisis of housing service providers. These people do God's work. They are out there on their hands and knees and making phone calls. And there's just so much burnout. Many of them have what's called lived experience. They've themselves been housed, and some of going through this is a very, very hard process to sort of reliving some of what they went through. And there's just such a high rate of turnover, which is heartbreaking when you see somebody who's making progress, has made a connection with a patient, a client, and then they themselves get burned out, and then that sets everybody back. There's a problem of timing. Okay, so we will have a patient who's about to lose their housing, and we call and try and get emergency housing, and it's take a number. Okay, and then they lose their house, they end up back on the streets, they're back on drugs, and then 4 months later, right when we've sort of lost track with them, we get a call from the housing agency. There's a bed available for this patient. So we have to do a better job of real time when there's a patient with a need, getting them in right then and there while the iron is hot, because waiting even 2 weeks, your chances of success go down dramatically. And then the last point I was going to make is that virtually every patient I encountered suffered from either a major mental illness or substance misuse or both. In my view, it's a health issue. If we're going to address homelessness, we have to address the medical piece of this. I'm not going to spend time on this because I already said it, but just wanted to acknowledge how hard it is to be a housing case manager, what difficult work this is for making not a very high salary. And my just final policy reflections, I'd love to get everyone's thoughts on this who are more involved on the policy side. Housing first, I know that Trump came out with some things. I don't even know where to begin on that. But I do not think that the housing first approach is perfect as is. I do think we need to have a 2.0 or a bit of a rethink on it. Housing first being get everybody into housing and then worry everything else later. Well, there's been a lot of interpretation of less emphasis on the services. And I think if you just put people in housing, but they're using drugs and they're not untreated mental illness, it's not going well. And that's not an efficient way. So I think housing first has to emphasize the services, not just the housing itself. Greater acceptance of harm reduction. If I have a patient in my office who's smoking 3 packs a day, I'm very happy if they're down to 1 pack a day. It's not perfect. And, we don't always do this. We kick people out of shelters if they have a slip up. I know there's an alternative side of that, but my view is if someone's working in good faith and they have slip ups, that you know, we have to keep giving them chances. It's a medical illness, and you can't expect perfection. And we need to get more creative on the housing side. I think the first thing is recognizing that it's not just build more, but it's also support the staff who are doing this work. The zoning regulations, I go downtown and there's these unused office buildings, and why can't we turn this into housing? Because of zoning regulations, that's above my pay grade, but it's just, it's craziness. And then we also have to be, I think willing to build up a little bit. We can only do two, 3 levels. And I know there's the counterpoint is some of these big high-rise buildings ended up not working out so great, but there's probably some middle ground there. But it's incredibly rewarding work. Unhoused people are some of the most resilient, grateful, amazing people I've ever worked with. Not to say they don't have their vices and their challenges, but just incredible human beings. And those who work in this space are as well. And success stories are possible. I wish I could say it was the majority of my patients who get successfully housed, but there are real success stories out there. And with that, I'll turn it over. Love to hear thoughts.
Well done, Dr. Hochman. Well done. Well done. Questions or comments? Madam Chair.
Thank you so much, Supervisor.
Did Ricardo make it back? I was looking for him. Ricardo, are you?
Yes, Ricardo's still with us.
Yeah, we were asking about
Supervisor, I'm here. I'm just multitasking.
Yeah, the question about
the
FQHC that Dr. Hochman posed. Did you hear his question early on?
No, I didn't hear. What was the question?
Well, my supposition is that a combination of that FQHCs are very well positioned to provide homeless health care in a sustainable way through a combination of the PPS rate plus enhanced care management, that it could be done sustainably.
I would say yes, but there's always some deficits. For example, I can only speak for our organization, that with the grant funding and funding from HRSA, PPS, and we even have CalAIM, there's still some shortfalls that we still have to help to cover with grant funding. And so in large part I would say yes, but there's still a need for additional funding.
Okay. Rhea?
Thank you. Well, Dr. Hochman, I couldn't think of a better way to end our 2025 year of homelessness working group meetings, because I think your presentation one really helped to address all the concomitant factors that lead to this moral crisis of homelessness. So thank you so much for that. And then I guess I have some questions. One, also, thank you for the work you're doing. If there's anything we can do to support, your new agency and becoming an FQHC, please feel free to let us know. And I'm sorry, it probably looks like I'm on twice because I had a speaker issue with my computer. So if you see my box muted and my voice still coming out, that's why. But I have a few questions, and then I'd love to open it up to questions for everybody. What are some ways that you see, I definitely resonates when you share the pressures that are on the team members that work at as homeless service provider agencies. What are some ways that we as the EC or Angelinos in general who are non-service provider population, what can we do to get involved or support the work that agencies such as yours are doing?
Well, I think it's in terms of specifically the workers, they are paid just such a low rate for surviving in LA. I mean, I hope this comes off okay. I don't know how someone gets by in LA and $25 an hour, and then these people are working, on paper 40 hours a week. But I talk to them and they're talking to their clients and they're texting with them on Saturdays, so they're working these 60-hour weeks. I just think there needs to be more funding and support for that type of work. I know there's accountability problems and waste problems and all this, but
Mm-hmm.
I just think in this area, and I think, how can the EC people help? I mean, I
Yeah,
think appreciation goes a long way. That when people feel valued and you come by with,
sure.
some Subway sandwiches or something, when you see someone out there on their hands and knees trying to help someone who's homeless, it really means a lot.
Mhm.
Okay. Thank you for sharing that and for your candor. Is there an opportunity for your field medicine teams as you share? Do you accept volunteers on those teams?
We certainly did at Healthcare in Action.
Okay.
Yeah. Yep. Yeah,
Okay.
I think a lot of, and I'll speak also, USC has a very good street medicine team. The county does, Venice Family Clinic. So there's a handful out
Hmm.
there, and I think that is very well appreciated.
Okay, great. And then my last question, and then I will open it up to the rest of our working group members is, this past Wednesday was World Suicide Prevention Day. And so we know, suicide is a devastating crisis as well. In the work that you do you notice is suicide also prevalent amongst the people that you serve?
As far as I'm aware, none of the patients, the 6,000 we cared for, suffered from suicide. We see a lot of overdose deaths. Whether some of
Got it.
that suicide is hard to say. And you probably all know this. Fentanyl it's a killer, and
Yep.
it's laced on other drugs. So someone takes
Hmm.
meth or marijuana and they don't know what they're getting, and they take more than they realize, and tragic.
Thank you. Thank you so much. Does anybody else? Oh, supervisor, go ahead.
So a question in the chat from Cheryl Branch. Cheryl, you want to pose your question?
Yes, thank you. Thank you. I sure will. I was trying not to interrupt. Thank you, Michael. That was a great snapshot of what's happening in the county. So I'm trying to think outside the box. And because I'm not a direct service provider, we see people on their worst day. They lost someone, they're about to lose someone, and we get all the stories. So I was thinking, how do we begin to look at these operating deficits and challenges from a systemic standpoint, not so much the program? There are these operating margins that we like to call, this is some of the financial pressure. How do we get a table of thinkers? We're thinking about ways to create some different like financial solutions, or it could be a policy. There are also the community health indicators. You laid that out very clearly. And so how do we begin to get at that through this system, the system? And then of course, how do we come up with some strategies to stabilize? Like, for example, the community hospital, it's beautiful. It's, meeting some incredible need and momentum, but I don't hear senior leadership from that team, and I don't hear the pressure to push them to this kind of innovation where we're really looking at our current reimbursement models. We know what we're dealing with at the federal level, the state level, but how do we think about some things like maybe having some kind of carved out payment methodology that's place based with the health equity metrics? I mean, we have to all the way unpack that. Some funding through a mixed state allocation, a little county reinvestment, a little CalAIM, a little savings, a little this. I just don't see in the civic engagement, we need a little participatory budgeting, which is the math. How do we look at the math formulas and that kind of dashboard drive some of these funding formulas? Because just math wise, what we have is not sustainable. It's just not sustainable. So we don't want to lose the whole kitchen sink. So just wondering, am I the only one that's looking at it that way? Should I be, adjusting my point of view to see this narrative that we hear from the consumers, the users, where it's just broken. Sometimes things, they just get broken. Like it's nobody's fault. It just is broken. What do we do? I just don't hear that. So what am I missing?
Well, the quick response is that this is a dynamic environment. And so if you go back to when we first began reimagining MLK Hospital, and let me pause to say thank you to Dr. Hochman for his acknowledgement of the list that we made. But I want it to be known that Vincent Harris played a critical role in that effort as we were moving throughout the state of California, going to UC meetings all over the state to get UC to buy into it. Yolanda Vera on the team was also in it. So it's clear that I get uh, a substantial amount of uh, credit, but it has to be said that there was a team working, making all of that happen. And, you know, at the time, it was the answer to the prayer. Um, it was clear that it could not be a traditional county hospital. The UC system would not buy into that. It had to have its own independent governing structure. Uh, so this is a tripartite arrangement with the state of California, the UC system itself, and with the county of Los Angeles. Those are the three institutional stakeholders. Fast forward to where we are today, literally 10 years since its opening, and it has done phenomenally well with respect to patient care and issues of that sort. It could be argued has been uh, overly successful. And Jack, don't be bashful to weigh in at any point, Dr. Barber, to refine or critique my comments. And so, a facility that was meant to accommodate 40 to 50 at max emergency visits on an annual basis is seeing north of 100 visits. That's math. And I want to say that it's the math that could be very, very um, problematic. When you made the point earlier, Cheryl, that is not sustainable, clearly not. We haven't heard any drama, any trauma of consequence at MLK, but you can't run a hospital like that in perpetuity. And it is the case that it needs to be larger. Um, and this is where the pragmatic progressive shows up and says, how do we get those 5 votes to swing resources to make it possible for the most medically challenged sector of the county of Los Angeles to get the services that it needs. Against the current political environment, there's contemplation of potentially closing one of those campuses or one of the hospitals. And so it's fair to say we're up against it, but the MLK model um, is increasingly challenged from a financial perspective because it is um, uh, the simplest way to explain it is a one off. That is, in fact, it is not a part of a system of care, and the lack of sustainability is directly attributable to that. And that was a concern when it was first launched. But some of you may or may not know, no one was willing to step up and cause it to be a part of their system. And so the point to be made was this: there was determination to go forward anyhow. And here we are a decade later, and it is a significant credit to the county of Los Angeles. Nothing to do with me per se. This is not me trying to toot my own horn. It is the objective reality of how many people have been saved, the quality of patient care, the feedback on the quality of medical staff, etc. Far from perfect for sure, but a whole lot of good can be said and has been done in that environment. However, it has to be system connected in order for it to do better. It has the campus itself, not simply the hospital, has more homeless serving uses than practically any other campus in the whole county. Mark Galley said he didn't know anything. Mitch Cat said we don't know anything like this really in the state or in the nation. And so when you think about recuperative care, Jack, on that campus, when we think about the issue of a behavioral health system, behavioral health center, the first of its sort in the state of California, on that campus, and when you talk about emergency or urgent mental health services, right there. And more examples to present themselves adjacent to a university that's drilling down on the question of homelessness itself. And that's where the training can come in, Dr. Hochman. You can train people with certificates and they can hunt these jobs and be I'm trying to drop some little lugs here. We need to be all about it so that we can make this happen. So this is work that can happen. Now, Barbara has been a little modest about how much of a consequential player he is in this whole area, but strong, long credentials in the mental health space, particularly at Drew and otherwise. Uh, uh, we got him out of NYU and over here to help us figure LA out. It was a little chilly in New York, Jack, I know. But you're here now, and we're happy about it, and we're glad that you've been here for as long as you have been. So those are a few rambling thoughts that we need to kind of really think through. It's not a matter of the current team, it is a structural issue, it's a systemic issue, and it has to be addressed by the Board of Supervisors. It has to be addressed by the state of California. It has to be addressed by um, HHS and the range of players that can have this. But the homeless piece of the puzzle is critical. It is highly rated. It was so effective. One anecdote will suffice. Someone had the bright idea, they shall remain nameless, a former city attorney, that they were going to sue MLK Hospital for patient dumping. And we said, we'll be damned if that happens. You got a fight coming forward. And when he got to the bottom of it, it became obvious, you recall this, Dr. Hochman, that they didn't know what they were talking about and that the work at MLK was far and away superior. Paramedics were bringing patients to the hospital because those homeless persons were being treated well. The final point that I would make in that connection is that same city attorney later decided, well, maybe we should showcase MLK. Let's match them up with Cedars and tell everybody that these are the two best examples across the county for providing services, protection, and dignity to homeless persons. And so a lot of times things are going on that the people in the space don't even know happen to be going on. But I conclude by saying it is a dynamic process, and what the answer was to the prayer yesterday could very well not be today. That's why we have to continue to update our Rolodex.
Thank you, Supervisor. I think
that was way more than I intended. Vincent provoked me.
I was going to say, I didn't know the end to that story with the patient dumping to best in the county.
Yeah, that's what
But I
happened.
think it answers a lot of questions on Dr. Hochman's last slide. So
Yeah,
we thank you, Supervisor. We thank you, Dr. Hochman. And of course, we get to thank Mr. Harris too.
yeah.
So,
And Dr. we got to thank Dr. Barber. Dr. Barber keeps
oh, of
me,
course,
you know,
Dr. Barber too.
I make no bones about the fact that he's a skilled psychiatrist, and he's one of my best friends in that regard.
No,
Thank you.
I,
Thank
we
I've,
you.
appreciate.
I've earned the relationship.
I think that's the reason why Dr. Barber is so quiet. He doesn't want to violate any
Um,
HIPAA.
Well, then you should take a note out of his page. Then I take your license.
okay. Well, I have a question that actually I think Dr. Barber and Dr. Hochman and Supervisor as well, you could really support us with this. Is when we think about the history of where we've been with community health, when we think about how we reached a field-based approach that we see works, right? From the data that Dr. Hochman you shared today, from what Dr. Barber has shared with us about SHARP, and from both the FQHC perspective and an agency that has a FSP perspective, and then the history of how we got here and even got to a place where we could have a community health hospital, which when Supervisor was sharing about MLK Hospital, right? It sounds like collaboration has been crucial in all of these pieces and really an intersectoral collaboration. So I think my question here is Dr. Hochman and also Dr. Barber, when as you present these innovative models, how has collaboration played a key? Has it, played a part? And have there been any barriers with collaboration, especially when we think about, what we call street medicine or Dr. Hoffman, where you've been sharing is field-based medicine. I mean, people are not always open to these innovations, but we do now see that they work, and so we hope more and more people adopt it as a solution. What kind of role has collaboration played, or has it been a barrier?
Yeah, I think caring for unhoused and any challenging population, it's a team sport. It's not just medical care, it's not just social work, it's not just case management, and all things are together. If you have an organization like Kaiser where it's all under one roof, that's great. But it also can work. We would nowhere near have been as successful if we didn't work closely with the recuperative care partners, the shelter case managers. They're the ones who keep the eyes on our clients when we're not there. The challenge, of course, is everyone's got their own siloed funding stream,
Right.
and everyone's funding stream is at risk constantly in the current political environment. So it makes collaboration really challenging. But Dr. Barber, please feel free to enhance.
Yeah. I think the silo effect on the services that we provide is kind of straps us from being able to do some of the more innovative things that we can sometimes create. It does require multi-systems to be able to be unleashed, to be able to work together creatively, and you have departments throughout the county and the city, and mostly the county, that are really sort of always protective of their own, and so it makes it very, very difficult. I mean, I just mentioned this is the fact that Dr. Hochman has had such great um, results and outcomes as a result of his ECM funded um, street medicine program that has been requested in other communities. And basically, it's health plans that have been able to push this ahead. So it requires not just the individual providers, but a large system of people who are insured. LA Care is the largest insurer, and it's a function of if I'm not correct, and Mark correct me, it's really if it was inaugurated as a board of supervisor initiative in some ways, and so we really have to look how we can braid funding, because I don't believe people are going to give up their fiefdoms, but we have to make this really this intentional braiding of services in which no one feels as if they're going to lose, you know, and that's so important that you have to check your some of your feelings at the door. And while we have, and while MLK has just done, I am so proud of MRT and the board of supervisors to put that together. That was no easy feat. It required lots of people to work together, and that was difficult.
Yeah,
and I understand that. At the same time, that campus, and if you want to say that, we've lost, 80 psychiatric beds on that campus, closed, or displaced or whatever, and it's a constant. It requires constant pressure and interaction among all of us, and I'm looking for opportunities all the time, and sometimes they come in the oddest ways, but thanks to the street medicine opportunity that's just presented itself most recently, I hope that it can maintain. Maybe Dr. Hochman with his FQHC organization will be able to pencil this out so that it can work with community partners so that it can flourish and continue to have great outcomes.
Maybe one day we'll hear about Starfield and Sharp working together even closer. So, okay. I'd like to allude to. Oh, go ahead, Dr. Hochman.
Oh no, I'm good. I'm good.
Okay. I'd like to also allude to something that Cheryl Branch put in the chat about advocating and educating state leaders about California disproportionate share hospital recommendations to federal leadership about the upcoming Medicaid DSH cuts. Vincent Harris also shared that MLK Community Hospital might not be DSH eligible, but questions should be presented to public officials in a setting that's open to community stakeholders so that a baseline of accurate information can be established from which to work on advocacy. So thank you both for that. With that, I know we've taken up a lot of your time this evening, Dr. Hochman, so I would like to ask if anybody has any last questions for Dr. Hochman as we kind of near the close of this meeting.
Yeah, I have one, and it's related to something I've been thinking about, and Dr. Hochman's presentation reminded me of it, and that is that are you aware of any sort of threat assessment that's been done in light of the current political and budgetary realities as relates to the provision of health care for the homeless? In other words, are federal and state and local funds at risk for financing the sort of work that you are doing, or for that matter, financing the work that is trying to address homelessness and housing insecurity and the healthcare needs of those populations?
I mean, I can speak to the healthcare side. The two big funding threats is the Medicaid population. The Affordable Care Act, Obamacare, we went from a 16% uninsurance rate down to about 7%. And with the federal cuts in the Medicaid, it could get back up to the same thing. And we might start needing those things like Healthy Way LA, which was it's been so long since I've seen an uninsured patient because everyone in the state of California is eligible for Medicaid, including undocumented. And, we're just not going to have the funding to keep doing that going forward. So the Medicaid expansion population is going to become uninsured again. And then the other second one, as I mentioned before, is CalAIM. That waiver finishes up at the end of 2026. That's been a foundation for all the wraparound care. Far from a perfect program. Trust me, I have plenty of ways to tweak it, but the answer is not taking it away. And that's a real risk.
Thank you. I was just thinking that certainly from a policy perspective and from an advocacy perspective, Rhea, it probably would be wise for us to think about what sort of threat analysis exists, or at least cause one to be developed so that we can project and anticipate what is going to happen, and to the extent our advocacy permits, avoid it from happening.
Sure. I think that would be great and right on track with, our Empowerment Congress mission to educate, engage, and empower. So with that, I can't think of a better way to close this out. So
I can.
Oh, Mr. Harris can? Okay, talk to us.
Well, in about a little more than a month, the Empowerment Congress is going to be convening a candidates forum for individuals who are running for governor.
Yes.
And so we should be encouraging participants on this Zoom meeting.
Yes.
To be ready for January the 17th, 2026. When that meeting happens, I'm dropping a few bits of information in the chat related to the summit, the 34th annual summit. I don't know if you want to say anything more about it.
I was going to say something in the announcements, but thank you for beating me to the punch.
Oh, I thought you were okay. Sorry. Oops.
That's okay. It's teamwork. Makes all the dreams work. So first and foremost, I want to say, Dr. Hochman, thank you so much for joining us. Thank you so much for what you and the Starfield team continue to engage in, and for really, keeping your foot on the gas when it comes to supporting our unhoused Angelinos, to bolstering health equity, and just to sticking with this, because we know it's a marathon, and we hope we are here to support, and we are so grateful for all that you do. So thank you, thank you, thank you. Thank you so much. With that, I could not think of, again, a better innovation and speaker to help close out our 2025 year for our Empowerment Congress Homelessness Working Group. As you know, the mission of the EC remains to educate, engage, and empower. And as my colleague, Mr. Harris, alluded to kick off 2026 on the Saturday of Dr. MLK Jr. weekend, which is January 17th, 2026, we will be hosting our 34th annual Empowerment Congress Summit. This summit is going to be a California gubernatorial candidate forum. So we really hope you will join us then. We can't wait to see you. It will be hosted at the California Science Center. So please check our website at empowermentcongress.org. Please check your inbox, and we hope to have you join us again. That is on Saturday, January 17th, 2026, 9 a.m. to noon at the California Science Center. Please note you have to register to join. Registration is required for entry. And the title of this, the theme for the 2026 Empowerment Congress Summit is A Forum to Unlock Participatory Democracy. So again, thank you for sticking with us throughout 2025, and we look forward to seeing you next year. Take care, everyone.